We're going to talk about this very important topic, and I really appreciate the organizers being flexible enough to move the session up. But it does set the stage in many ways for the rest of the meeting. So once again, my disclosures. So when we were planning this meeting, Gaur and I were talking about this, that, many of conferences, all the lectures are very esoteric and very it's all data intense. And it's very hard for people who spend most of their time just in clinical practice to be able to take that away, distill the information, and figure out, how do you take this back to your clinic? So I've framed this conversation today in 3 simple steps. And we will talk about the use of NITs in the routine practice. And so this is really based on how I manage patients myself. And this is how we teach our fellows and faculty as well. So it's really breaking it down into 3 simple steps. First, ask yourself, is there excess fat in the liver? Or does the patient have NAFLD, or is it MASLD, whatever you want to call it? More importantly, is it the kind of disease that's likely to hurt the patient, and therefore is intervention needed? Once you decide that you are going to do an intervention, and the rest of the meeting is all about what kind of interventions, the question is, how do you follow the patient? So we'll frame the use of non-invasive tests to answer these 3 questions sequentially. So when it comes to talking about NAFLD, just by looking at the risk factor profile, you can get a pretty good estimate of whether somebody has excess fat in their liver or not. And these are data that are compiled from many different sources. And it shows that particularly if your BMI is over 30, you have type 2 diabetes, if you have features of any existing cardiovascular disease, hypertension, and something we don't talk a lot about is hypertension as a risk factor. But all of these, and particularly if you have 2 or more features, then 90% of these patients will have excess fat in their liver. So the first question, you probably don't even need much of any testing. You have a pretty good, it's what we call the pre-test probability is so high that no matter what you do, if you didn't do any test and said, yes, you have fatty liver, excess fat in your liver, you'd be right 3 times out of 4. This is the much more important question that you have to ask yourself. That is this person with all these risk factors have enough fat in the liver, and is the fat likely to cause a problem for these patients? So let's spend some time into this. So now we get into some of the science and the driving principles of how we think about this. So the likelihood of having MASLD can be inferred from the profile of the comorbidities. So that's the first point to take home. So obese diabetic patient has a 75 to 85% probability that they have excess fat in their liver. And the focus of the initial assessment is to identify those with stage 2 or higher fibrosis, because that identifies the population at increased risk of outcomes in those with clinical risk factors, which are excess weight, prediabetes or diabetes, hypertension, or suspicion of liver disease. Patient presents with abnormal liver enzymes. And of course, you have to exclude, different things that could also be present, because there's no reason why somebody cannot have 2 different forms of liver disease. That doesn't make it doesn't really create diagnostic confusion. We often will see people with more than 2 liver diseases simultaneously. So here is a critical element in how we think, and that is that the disease prevalence affects the performance of the NIT where it counts. So let's imagine in the middle over here, you have a receiver operating curve. It's a beautiful looking curve. You have a NIT that performs beautifully. So from this curve, you have a certain sensitivity and you have a certain specificity. Now, in primary care, where the prevalence of disease of the phenotype you're looking for, that is people who are scarring up their liver, is relatively low. Over there, when the prevalence is low, with the exact same sensitivity and specificity, your negative predictive values are going to be high, your ability to rule out will be high, but your ability to rule in, or your positive predictive value, will be low. Conversely, if you enrich the population, if you do something that increases the prevalence of the disease you're looking for in your population, then increasingly your positive predictive value will go up, but then when it gets very high, your negative predictive value will go down. So the prevalence of the disease, you don't make clinical decisions based on sensitivity, specificity, or the OROC. You make clinical decisions by saying, yes, I think you have this. No, I don't think you have this. So negative and positive predictive value is dependent on the prevalence of the condition. And so you have to be cognizant where the test was done and in what population, because your interpretation of the information, the same results will be interpreted differently depending on where you saw the patient. This is probably the single most important take-home message from my entire talk today. So this is exemplified in a different way here, where we look at advanced fibrosis, and population studies show that advanced fibrosis is present in 1% of the general population, which is like a family practice population. A diabetes clinic, it's more enriched, 10 to 20%. And if you come to someone who's in a liver transplant clinic where people are getting referred, it's going to be somewhat higher. So if you just look at a cutoff of liver stiffness of 8, which is often, everybody talks about 8 as the number for start thinking that, yes, now you have some scarring going on. You're in a family practice setting, when you do that, many of these patients, when you bring them in and you do additional testing, you'll find they don't have advanced fibrosis. This is also responsible for the high screen fail rates in many trials, because people just go everywhere and use the same cutoff to make positive or negative predictive value assumptions. So for the same cutoff of liver stiffness of 8, your ability to diagnose somebody with significant fibrosis is going to be different based on whether you're seeing them in your referral, advanced hepatology referral clinic, or whether you're going into a primary care clinic and doing screening over there. Now we have an extensive, with those core principles behind us, let's look at the toolkit. So I'm going to focus on the established biomarkers. We're going to start with FIB4, FibroScan, talk about ELF and MRE. And then there's a whole bunch of new things that are in development. I'll touch on them, but really not go into details. So now there are about 8 or 9 different society practice guidelines, and they all essentially mirror something we proposed about 10 years ago, where the principle was that the prognosis is linked to fibrosis. And so we use FIB4 as a simple cutoff, and a FIB4 of 1.3 is a line below which there's a high negative predictive value. Positive predictive value is very poor. But as you go above 2.6 and particularly above 3.25, then the positive predictive value for advanced fibrosis is much higher. Now, FIB4 was developed to identify advanced fibrosis, not to do all kinds of other things. And then if you're above 1.3, then you use secondary tests like FibroScan and other kind of tests. So the core principles are the same across all of these different practice guidelines. So you start off by thinking about in someone, if you have a diabetic hypertensive patient, you know they have excess fat, it's a simple computation to look at FIB4. If the FIB was over 1.3, it's not a perfect test by any means. You start thinking about how to proceed. So historically, we always looked at FIB4 as a marker of fibrosis. But now we actually have outcomes data. We can go to what really matters, whether the patient is going to have outcomes. So this is a study where we had almost 2,500 patients followed prospectively, and we show the incidence rate of clinical outcomes for people who had a FIB4 less than 1.3, greater than 2.6, or in the middle. And you can see all-cause mortality progressively goes up. particularly in those with high FIB4. Similarly, liver events dramatically goes up. The incidence rate goes from 1.3 to 9.3 between the middle category and the other category. And then the MACE again goes up, and so does hepatocellular carcinoma. So while it is not a perfect, by any means a perfect biomarker, and there are cases where people have low FIB4 and have fibrosis, by and large, you'll be on the right track. Those patients somehow don't seem to experience high incidence of mortality, etc. And the overall mortality data for those with a FIB4 less than 1.3, at least in this cohort, and there are now a couple of other confirmatory studies, are more or less like the background population. So if you look at all patients, the other possibility is that at a certain age, and this is our practice, all patients at age 40, I think, should have a one-time evaluation of their metabolic health, and probably should occur even earlier. I think we're beginning to lower that number down to like maybe right as they're moving from pediatric to adult age, when you can actually do something. This is maybe even too far advanced. Those who have risk factors, or if you have clinical suspicion based on imaging or ALT. You rule out viral hepatitis, you talk about alcohol, you do risk-based assessment and management if there's a significant concern for either of those. And our current party line is, if you got any kind of liver disease, no alcohol for you. So that's at least medically the correct decision-making pathway. Check your FIB4, and so if it's less than 1.3, you have a low probability of outcomes. You can repeat in 1 to 2 years, and your focus is then mental health, behavior, health literacy, remove barriers for lifestyle, engage in a more healthy lifestyle. What to do when it is higher? So now let's move to the right-hand side, where it's greater than 2.6. It is clinically enriched for outcomes. So remember that positive predictive value thing we showed? Now you've enriched that population. Now we need to do a secondary test to confirm if they have cirrhosis, because if they do, you're going to start doing screening for hepatocellular carcinoma, varices, all kinds of other things. Now we often will use FibroScan as the secondary test. And all of you, even in the past, they say, oh, we would use FibroScan. So one of the critical things with the FibroScan or any test is if you did the same test 5 times in a row, how much would the variability be? If I did it now and then Dr. Koshi came and did it right after me, how much of a difference would there be? And if Dr. Siddiqui came tomorrow and did it with a different machine, how much would the variance be? Even though there are 1,000 papers on FibroScan, this actually was not known. So we actually went ahead and did a study and answered this, that this data is currently in press. So what we find over here, and this is called the Obuchowski index, or the different day, different operator coefficient of variation, and it's 35%. What that means is that if you get a liver stiffness of 10, truth lies somewhere between 7 and 13. Because if he came after me or you came after me, you might be somewhere in that range. So different day, different operator coefficient, 35%. And then, of course, same day, same operator, it is a little bit lower, around 20%. So based on this, when you follow people over time, a 30% change is emerging as a significant change because you're rising above the noise. Otherwise, you can never be confident, is the difference is simply because it's a different person doing the test, or did something really change in the patient? Very important second take-home message. So then, if you look at how clinical decisions are made routinely, often it is based on poor understanding of biomarker science that carries the potential for harm. I need to put my glasses on so I can read my own laptop over here. So these are data that Dr. Siddiqui did many years ago as part of the NASH CRN that we worked on together. And what you see is fibrosis stage 0 versus 1 to 4, 0 to 1 versus 2 to 4. You can read that. You have the aurochs next to it. You have the cutoffs. And then we did 2 things. One, to rule out, we held the sensitivity at 90%. And then we looked at what the specificity would be. And then For the rule-in, we again looked at the cutoff and then held the specificity at 90% and looked at what the sensitivity would be. This is a very important and a common practice when you're validating biomarkers. So if you look at this data, what you will see is that 1 out of 3 patients, the specificity, 1 out of 3 patients with cirrhosis will be missed. These patients will not get HCC surveillance. And those for clinically significant fibrosis, if your cutoff is 5.6, 3 out of 5 actually will not have it. And a cutoff of 12, 3 out of 5, when you use the high cutoff, 3 out of 5 with clinically significant fibrosis will be missed. So that shows you that there is noise in all of these biomarkers and that you have to be aware of it, that, you know, there's a certain amount of error range within all of these biomarkers. So how do you then deal with all of this? So what to do? This is now very confusing because we just threw a bomb in the middle of all our preconceived ideas about what cutoffs to do and what decision making to do. So you're back to basics. You come back and think about what's the a priori likelihood that the patient has clinically significant fibrosis, and we're particularly interested in finding out who has advanced fibrosis because they are closest to outcomes. They are the ones where even in the absence of approved drugs, but in India you have approved drugs, that's the population of greatest interest where you can intervene. And so of course, the higher you go, then you have enriched the population so you'll have higher positive predictive value. So then you have greater certainty that you are on the right track. The other is, for these reasons, of the limitations of liver stiffness, secondary scores have been developed. So for example, the FAST score was developed to identify clinically significant fibrosis, stage 2 or higher, with a cutoff of 0.3. Similarly, Agile 3 score is developed essentially to identify those with stage 3 or 4, which is called advanced fibrosis, and Agile 4 for diagnosis of cirrhosis. This is all now published, and we've actually shown this actually correlates with clinical outcomes as well. The ELF test is the only, at least in the West, approved test for prognostic indication, not FibroScan. ELF test is the only approved test for prognosis for NASH. And as you know, it was developed as a fibrosis biomarker, has 3 components, but there's a proprietary formula that gives you a number at the end. So you cannot just run the 3 and add the numbers up. And these are the data that were used for the approval. So on the top panel, what you see is that for those who started with F3 fibrosis, if their ELF was over 9.8, the hazard ratio was about, for progression to less than 9.8 hazard, that's the baseline. 9.8 to 11.3 hazard ratio jumped to 2.3. Above 11.3 hazard ratio jumped to 4.5. So as you go with higher ELF score above 9.8, that's the magic number. If you had F4, if you apply the same thing, you see the people who had an ELF over 11.3, they had a significantly increased. Those are the people who actually had clinical outcomes. So you could do a FibroScan, and certainly in the West now, ELF is the next test to do for that high-risk population because it identifies those closest to outcome, and then in that you can apply Baveno criteria for clinically significant portal hypertension, etc. So it is important also to understand the relationship of the cut points that you use, because it's very confusing when you read the literature, because some studies will use a high specificity cutoff, a high sensitivity cutoff, but in real life, nobody can remember 500 cutoffs for each test. Everybody wants to know if it is this, if it is more than this, I should go right. If it is less than this, I should go left. So I think knowing this relationship is really important, and more of the literature actually reflects that. Those of you who are in academics here, and if you're doing biomarker work, this is really important. You should show this data in your papers. MR elastography is the other tool that is now lots of literature on it. And we will see data later in the year. This is going to be a very active year in NASH. You're going to see some amazing pharmacological results and amazing NIT data, but I cannot share with you now because it's not in the public domain. But MR elastography has been linked to clinical outcomes, And we know both for prognostic and later in the year, we'll see data that it also, as MR elastography improvement correlates with improvement in histology as well. So particularly if it's more than 8 kilopascals, very high risk of outcome. It would be similar like 11.3 with the ELF. So if you don't have ELF, you can definitely use MR elastography. Then, but MR also has issues. MR has a reproducibility issue also, and it's up to 20%. So MR elastography is not the precision tool everybody thinks. There also you have to have more than 20-25% change before you know there's a real change. Now the MR for measuring visceral adipose tissue, PDFF, etc. are actually much better. And then similar data with corrected T1, where above 825 is a magic number for those who have clinically significant fibrosis. And then recent data will come out actually showing that this is true as well. So you can take this algorithm and particularly focus on the people in the middle, whereby you can apply the NIS. There are other tests like the NIS2, which you don't have, so I'm not really getting into that, but you can apply the FibroScan-based tests such as Agile 3, 4, with or without ELF, and you can reclassify the patients into those who have particularly with increasing risk of having a clinical outcome. And then based on increasing risk of clinical outcome, you can have increasingly aggressive therapeutic approach for these patients. One size does not fit all in this population. So here is where we end. And this is basically the way we manage these patients. Going back to that FIB4 algorithm, if it's less than 1.3, repeat in a couple of years. More than 2.6, if the ELF is greater than 11.3, that's the highest risk strata. Here, the people that we see more frequently track their MELD score because it starts declining. We start moving them towards transplant. ELF less than 11.3, we may use 2D MRE or a corrected T1 to reclassify the patient based on risk, to either move them into the red bucket or to try to move them to the left, to the lower bucket. And if it's in the middle, you have multiple choices. You can repeat in a year's time, or you can do secondary, based on FibroScan, you can compute the Agile 3, Agile 4, or FAST score if you don't have the NIS available, and then reassess whether you can reclassify some of these patients into low risk, moderate risk, or high risk. If you're in the moderate risk, you need to follow the patient more carefully. They also may be qualifying for pharmacological therapy. And then eventually a couple of words about how to follow. VCTE is beginning to emerge as an important way to follow these patients. Multiple drug trials have shown that VCTEs can capture improvement in histology. This is just summarized over here. And keep an eye on this. I think there's much more to come on treatment monitoring later in the year. Thank you.